हेलो. हेलो.
हेलो. यस.
मॅम
मैम बोलिए.
तुम्हाला
तुम्हाला
करतोय.
करतो. हाँ.
को होस्ट करतोय मॅडम मी तुम्हाला.
ठीक है. डॉक्टर हेतल जॉईन झाले आहे. हेलो. हाँ सर, आप देख लो ना, आपका प्रेजेंटेशन जो लो ना.
Ha ha. Good evening.
Good
Good
evening.
evening.
Good evening.
Yeah.
Can you see it?
Yes, yes, yes.
So I'm starting PowerPoint. Okay. Slides are changing.
Yes, 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 sir.
I'll play one of the videos so that.
Are gathered here today for this second webinar from Team ISA Thane. And we are very happy to have two very young our members, Dr. Anjali and Dr. Aditi, who will be presenting two talks on how they do certain surgeries. And of course, our guest speaker today is Dr. Hetal Vadera, who is very prolific on Facebook and YouTube, and he is quite sometimes the go-to person to look at the video before attempting some blocks. So welcome, Dr. Vadera. And Dr. Parna? Yeah, Dr. Parna can now take over and start the rest of the webinar. Parna?
You get started, no? You get started. Yeah, introduce it. You
Yes,
can
so
introduce.
today you can go ahead, Parna. No problem.
You start, Manisha. You
Okay,
start.
okay, start.
Yeah.
So our today's moderator for today is Dr. Chittaranjan Das. Dr. Chittaranjan Das is a very important and versatile anesthesiologist of Thane city. Besides being an anesthesiologist, he is also a pain physician and has his own pain clinic, Ankur Pain Clinic in Thane. And he gives a lot of nerve blocks for pain relief. And we are very happy to have him as our moderator today. So Dr. Das, please take over.
Thank you, Dr. Manisha. Good evening, everybody. Today, I am happy to introduce Dr. Anjali Milind Patil, who is our very senior anesthesiologist in Thane. She is practicing since 1998 as a freelancing anesthesiologist. She was attached to a Singhania hospital. Previously it was there in Thane. She finished her MD from BJ Medical College, Sasul, and she has finished her DA and MRCA from London. Now today she will talk about post-operative analgesia for the total knee arthroplasty. Dr. Anjali, please start.
Yes.
Please.
Yes. Good evening, all. I'm sharing my screen. Let's see if, let me know if there are any hitches. Okay. So first of all, thank you to all of you for finding time this evening to coming and joining this and listening to all of us. Second, thanks to Team ISA for inviting me and letting me, express my views on this, my beloved topic rather. So, my topic for today is post-operative analgesia for TKR surgeries or total knee arthroplasties. The better definition of the topic is how I do it. So, all the academics and the ideal situations can be a little afar. Okay, so it is only how I do it. Now, I've been doing these surgeries or doing rather anesthetizing these surgeries since the last nearly 28 years. But the actual lovely outcomes have started coming, outcomes in the sense post-operative analgesia, management of post-operative analgesia are better and best since the last 2.5 years, since the time I have entered into the world of sono-guided blocks, I should say. Now, why did I ever start this? Honestly, we at Revival, I mean, I think most of you know the place. We at Revival have started doing robotic surgeries since the last 2.5 years. The robotic surgery, because of lesser of dissection, lesser of cuts and all these things, are supposed to give the patients a pain-free post-operative period. So I thought of doing my bit, and that is how I thought of starting these things. Honestly, before I start, I have to thank a few people who were very instrumental in motivating me and in pushing me to learn these things at that age. Now, my first thank you goes to Dr. Bala Venkat. He is my senior in BJ Medical College, where I graduated. He was the person who really pushed me into starting the sono blocks, into getting the machine, and really he helped me out. So thanks, Bala. Second person is Dr. Dilip Chavan from Thane. I think you know him, most of you know him as well. He helped me out with my initial blocks and all the other technical things. Last but not the least, I have to thank my dear surgeon who patiently waited for in my learning curve, 15 to 20 minutes to give one block. And that is how I could learn, do, and achieve this post-operative pain relief today. So thank you, Milind, as well. Now, getting to the topic, actually. Why did I put the picture of adductor canal first? Because this is what has really revolutionized my post-operative management. I have divided this topic or my talk today into 3 parts. The first part is the multimodal analgesia. The second part is a small, small amount of statistics which I could do with my data. And the third part, of course, is an open forum. We have people who are pain experts and maybe doing these surgeries more than us or longer period than us, who are managing better than us. So all the suggestions and all the other ways are most welcome. I would really like to hear from them as well. So we start this. This is the agenda for today. One second, I'll just yeah. So these are the three things which I talked about. Now we start with this multimodal analgesia. Somehow, to manage the post-operative pain nicely, the actual management starts from the pre-operative period. Maybe I am one of the lucky few who can actually meet the patients, interact with the patients, and explain to the patients, relieve their, anxiety nearly a week or 15 days before they actually go under the knife. And this is because as a protocol, we usually get those patients doing their fitness tests and coming and meeting me or Anaga or Jayashree, whoever, all three anesthetists from Revival, one of the three. All of you may not be able to do it, but this is a sincere request. Who all can do this? Please get into the practice of meeting them pre-operatively. When I started off this, I was really surprised to know that the patients are super anxious to give their leg or their knee to the surgeon to operate. Second thing is they are more scared of the spinal anesthetic injection in the back more than the knee surgery. And that is really surprising, but they have heard so much about different things about the spinal anesthesia that when you go and tell them that you will be half anesthetized or you will get spinal anesthesia, they are really, really scared and anxious. Many of them still think that the injection or the big needle is going to go into their bone and the spine. So alleviating these sorts of anxieties, talking to them, explaining to them what they are going to face, really helps in alleviating all their anxiety, and so getting their pain perception or their pain perception less and their morale high post-operatively. So pre-operative counseling, I will give a star mark to this. Let us go ahead. Now, the second thing, we usually admit the patients the previous night just to give them a mild sedative and of course, antacid, but a mild sedative like Zolfresh or Restil or something by which they have a good night's sleep so that they're fresh and fine in the morning of surgery. The next thing what we do is, what I have started doing since the last, again, 1.5 to 2 years is, I have started applying prilocaine gel or cream at the site of the expected spinal injection. Now, I don't know if any of you is doing this, but this is just an idea I had and I started doing that. Now, who does that? Actually, I have trained my staff to put this Prilox gel at roughly at the place, like if I tell them to keep their hands on the patient's waist and wherever the fingers meet, the thumbs meet behind at the midline, they apply the cream about an inch. The cream and spread about an inch with, of course, a plastic and a dressing. What has it done? You will be surprised, since the last 2 years, after I have started applying this cream like that, the incidences of all sorts of, vasovagals and the moving and the ouches and the shouting, everything has gone to zero. I have had no vasovagal. I can proudly say that for all these 2 years. Not that we face it every day, but yes, it can happen because due to the knee trouble, the patients are limping so many times. They have a very bad spine, bad scoliosis, etc., etc. The spinal may get difficult. So this is one practice. I will again request whoever can do this, please start. It is worth a try. The next thing is I apply a buprenorphine patch, a 5 mics patch to all the patients at 6 a.m. in the morning. This patch is a 7-day patch, which the patients remove themselves at home. They have been given the instructions how to do it, etc. But this patch takes nearly 5 to 6 hours to start full action. So we put it 6 a.m. We start all the surgeries at around 7:38. So by the time the spinal action goes, the patch has acted totally, and there is at least some baseline analgesia there. As you all know, bone surgeries can be extremely painful post-operatively. The next thing is, of course, injection paracetamol, Neomol, 100 ml over half an hour, about 20 minutes to half an hour before incision. That is, once the patient is just before shifting the patient, we give this in the ward. It has been seen and observed. There are quite a few, theories that Neomol given in such a way definitely helps in alleviating the post-operative pain. The next thing, of course, is the spinal and epidural. Most of the times, epidural is not required, at least in the first 24 hours after we have started giving the blocks. But still, I keep it in, more so for the physiotherapy, which can be very painful as well on day 2 and 3. So epidurals I put in the epidural still before I give the spinal and keep it for the next 3 days. So epidural is another one. The next is I put in Zonac suppositories after the spinal anesthetic, of course, just to have another pain relief module. Now coming to the most important thing which we have started since the last 2.5 years and which has given us a very good pain relief is the adductor canal block and the intra-articular injection of local anesthetic, which is done by the surgeon, of course. So these the crux, these are the things which we do for each and every patient with a fabulous result. Now locally, again, the canal block, it is as standard. It is 20 ml of 0.2% ropivacaine with dexamethasone, 8 milligrams. For the local anesthetic, local infiltration analgesia, we give ropin. Actually, ideally, they say that it is nearly 100 to 150 ml of 0.2% ropin, which is to be infiltrated, super diluted, and along with the additives. I usually give 25 to 30 ml of 0.2% ropivacaine with, just a minute, with ketorolac 30 mg, that is 1 ml, and fentanyl 25 mics. Now this solution is diluted or made up to 80 ml by normal saline. This solution is injected by the surgeon intraoperatively in the knee. Actually, Dr. Patil doesn't like any, steroid in the knee. So that is not in the list. Now, epidurally, if in case the patient needs a shot for pain relief post-operatively, actually 6 to 8 ml of 0.2% ropivacaine SOS. This is a very standard, standard drugs and standard concentration, nothing new. Now, in adductor canal block, I give the block in a very standard way, no deviations. But as statistics, I've made a few tables to tell you how by little bit of experience, how by giving many, many blocks, your results go on getting better. So till now, this was made about a week ago. So till now, nearly 1430 blocks have been given by me till date. Few were initial, which were not that great, but I I can say now I'm getting better. So in the statistical charts, when we say best blocks, I mean, I have written it, ki my best blocks, then moderate blocks, and not so good blocks. So I have a protocol of putting a star after I give a block. When I enter the data, I have a handwritten data for all the blocks. So when I enter, I usually tend to make a star on a block which I feel was good, was given nicely. I have recorded the blocks as well. So that retrospectively, I can see which blocks, what kind of blocks, when I give how the patient's pain is 0. That is what I try to achieve. So best block is when you give the block in the adductor canal and the artery dips down in the canal. That is when you are sure you are in the canal. That is the best block. Then the moderate and the not so good are the rest ones. Now I have seen that when I have started the blocks, nearly 90% of the patients had no pain in the first 24 hours at all. Then the moderate blocks, we have seen about 20 to 30% patients had to be given 1 or 2 shots of epidural. And with the not so good blocks, those are the patients who were, say, like 100 kilos. 100 kilos, 110 kilos, or where I could not reach the canal, or I could not give a satisfactory block to my expectation. Those are the patients who needed actually epidural pumps. Now, epidural pumps I have been given, we are giving, or I have been putting for the last so many years. Disadvantages is that once you put a patient on the epidural pump, the cords go weak after some time, and the patient cannot be mobilized or cannot be ambulated soon. So now is the era of early ambulations. So these blocks helped me beautifully to ambulate the patient on the same day. So we have a protocol now that in the morning, say we start about 7:30. If the first patient or the first half, the patient in the first half, usually walk on the same day pain-free. I have got a couple of videos I could get and put in my talk actually, and it is beautiful to see their faces like that. I'll just okay, one more thing. At least in my finding, I could not find any significant difference in when I gave the block pre-operatively or post-operatively. Usually there is I have seen or heard of people who give blocks, they all give blocks. The adductor canal I'm talking about post-operatively, so that nearly 2-3 hours of spinal anesthesia, the 2-3 hours of pain is saved later on. But I have seen that once you release the tourniquet, the thigh, because of the reactionary edema maybe or whatever, the thigh becomes a little bit edematous, and giving the block becomes sometimes difficult. So in my practice, as our protocol, the blocks are always given pre-operatively. And there were a few blocks for trial sake I had given post-op, or when there is a bilateral TKR. For one knee, I usually give the block pre-op, and for the second, I give post-op. Not for judgment, more so for the dosages, because all 4 go together. So just to, give a time gap between the 2 doses of ropivacaine. There were a few patients who we did revision TKR on, a lot of patients rather. So without the local infiltration anesthesia, that was my test, whether only the adductor block with the multimodal things can suffice to reduce the pain. And nearly 75 to 80% patients of revision TKR, where we do not infiltrate in the knee, had beautiful pain relief. So I was happy. This is just, see, the phase 1, 2, 3, 4 were the first. This I have, divided into, I've taken 300 cases in each phase. And you can just see, this is just a very simple statistics that in phase 1, there were 32% patients who were in pain. And till I reached my phase 4, there were 25 and less. Here also, if you see that in the first 300 patients, nearly 30, in the first 300 patients, nearly 34 patients required an epidural pump actually. Even if I did 300, it takes that much of a time to, go perfect maybe, or go near perfect. And in the phase 4, if you see, there were only 2 patients who required pump. And maybe in the last month, there was not a single patient who required any sort of epidural pump. Everybody walked nicely on day 1. This is another this thing where, again, out of 300, 110 first patients required 1 or 2 epidural shots, not a pump, epidural shots for their pain relief. There are a few patients who have RA and all these things, or their other leg can hurt, their hip is hurting, ankle is hurting, all sorts of things. So anyway, so 110, and till I reached my 4th phase, that is more than about 1,000 patients, 66 out of them still required the epidural shots. So totally in all these cases, which I could get into statistics, 28% of patients only required my epidural. All the rest were managed only with the blocks. Advantages of pain relief, everybody knows. I'm just going through. The patient is better compliant. They can do physiotherapy better. They are ready for the next knee better. Early ambulation has got its own advantages, like no DVTs, no embolisms, lesser complications, and of course a spining patient. So I'm just running through a video of the adductor canal block. I could just get one in due to the time restraint. Nothing to explain actually. Just a minute, I'll just go back a little bit. Yeah, so this is the sartorius muscle. This is the adductor canal. This is the artery. This is my needle, which is coming from the lateral side. And I cannot appreciate in this picture actually. This is the lowest part, the most dependent part of the sartorius muscle, where I am giving this block. So this side is the femoral canal. This side is the distal adductor. So this is somewhere in between where I tend to give. And this is near best block, which I have tried to show here. If you can see, this local anesthetic is spreading and the artery is dipping. I'm sorry, I couldn't get a better video installed in this. So this is the artery which is dipping down. As I am giving the local anesthetic, this artery is dipping down here. Okay. So this is how nearly this the artery dips right up till here, goes up again as the local anesthetic spreads. Let us see the actual patient now. So this is the lady we operated in the morning at 7:30 as our first case. You can see the epidural catheter patched here. There is a URI bag here, so that I tend to put the urinary catheter so that they have less trouble passing urine. And this is the day of surgery in the evening. So anything for this smile. Another one. So she was a very obese lady actually. And I was a little bit unsure how the block would act, but really it was very, very nice to see her walking pain-free with a smile, of course. So thank you, everyone. And I open this talk to everybody else's views and suggestions. Thank you.
Thank you, madam. It was a nice talk.
Thank you.
We got a lot of pearls of the wisdom, small things, which will help us to do all this very smoothly, to this type of surgery very smoothly.
And anybody has
Till
any
now,
questions,
till
most
now
welcome, Dr.
there is
Das.
no question at till now. I have not seen any question. We will do the question answer session afterwards and the last. Is it
Okay.
okay? Okay.
Can I tell something?
Please.
Yeah, please.
Yeah, so it was a wonderful presentation by ma'am. I'm really impressed by data collection and the way she has improved day by collection of the data, introspection, and improving the technique. Madam has nicely talked about multimodal analgesia for knee surgery. This is something I want to share. This is actually prospect guideline for the knee arthroplasty. That is procedure specific guideline recommended by ESRA and ESRA.
Okay.
So they tell that in the preoperative or intraoperative period, we can give paracetamol along with non-steroidal anti-inflammatory drugs or COX-2 inhibitor. A single short adductor canal block should be given perioperatively, and periarticular local infiltration analgesia administered intraoperatively. Combination of these two techniques is preferred. Dexamethasone is given IV, and intrathecal morphine should be used whenever it is required. So what Madam has done is perfectly all right, and she has covered all this part. Like she has given paracetamol, she has given diclofenac, she has given dexamethasone and blocks along with LIA and epidural for rescue. So this is wonderful to provide analgesia for the patient. Thank you for sharing your experience, ma'am.
Thank you. Thank you.
Madam.
Yes.
Hello.
Yes, please.
Madam, can we give adductor canal block without ultrasonography?
Actually, no, because it's a very deep block as far as my knowledge goes. It's a very deep block, and by the location technique, it is not that great. I mean, I have never given it. I have never seen it being given. So the best way is to do with a sonography guided one.
Yeah, of course.
Even not with nerve stimulator, madam? Madam, can we give it nerve stimulator?
Nerve stimulator also, actually, it is not recommended to give it with a nerve stimulator. But if somebody is very good at it or what, I am honestly unsure, because I think best to give is through sonography guided.
Because as many of centers, we don't have ultrasonography, madam.
I know. Because I also, actually, I also never thought that I could procure the machine that fast and, do everything. But it was a very smooth process, honestly. Because maybe it is a single hospital and single-handed use of the machine. Maybe because of that. Because I was concerned of the PCNDT and all these things. But that didn't come in my way. And thankfully, I had the machine, but I think it is best to give it ultrasonically only.
Actually, you can stimulate the nerve to vastus medialis with PNS. So you can give the block to nerve to vastus medialis. For saphenous nerve, also it is written in the theory that you can stimulate the sensory component of sensory saphenous nerve with high current like 5 milliamps, and patient will have some paresthesia. But as Madam said, it is a bit difficult with PNS, but very easy with ultrasound.
Yeah, it is very easy with ultrasound because visualization is very, very... In fact, there are fewer other, blocks which they have described about dual subsartorials and all these things. But what I have seen is, for me to give dual subsartorial is a little tedious, I feel. So when you give LIA and this combination, whatever nerves, sometimes there are nerves which are missed in the adductor canal, they get caught with the LIA. So the analgesia is quite fine again.
So, madam, there is a question.
Yeah.
Thank you, madam.
Any post of spinal headache because of early mobilization, post-spinal headache, what are the chances?
Okay. Now,
have you ever come across with this because of early mobilization?
Yeah, surprisingly, I have got spinal headaches in patients of scopies and young tibias or all these things where we mobilize them, who are young adults. Our zone of patients are all geriatrics. They are all mostly above 55, 60. These days, 49s and 59s are coming, but mostly they are all 60 plus patients. And touch wood, people have not had any spinal headache, not a single case, honestly, of TKRs I'm talking about. Yes, I have had cases with people with arthroscopies and ACLs and other such surgeries, but where I've given spinals. But those are the ones, honestly speaking, all these maybe teenage and early adults who are on mobiles the moment they reach the bed. They're up. How much ever you tell them not to do it. Typically, I mean, I have really told them, you go home tomorrow, you're going to have headache, and they have headache. Really, I mean, it is that bad. But those are the patients who are really not following your instructions, and all these early patients. But all the patients who have ambulated on day one, geriatric age group, or I can say 55, 60 plus, not a single case of spinal headache.
Another question, madam. Have
Yes.
you ever repeated the block in the ward?
No, I have not. The thing is, in TKR surgery specifically, the most painful period what we have is in the first 24 hours. We have seen that the next day and the day next, unless the knee is extremely bad and you need a lot of dissection and all these things, only then the pain persists, but which can be sorted with an epidural shot. So again, going to the ward and giving a shot is actually not. I have not yet needed to give a block like that again in the ward, because the pain in the day 2 and day 3, see, because of the blocks, there is one more advantage I forgot to mention, that the hospitalization time has reduced. Initially, the first day used to go with the epidural pump. The second day would be settling the patient off the pump and this, then mobilization, this, that. And the patient used to be discharged on day 4 after 4 days of antibiotics. Today, we discharge the patient on day 3, that operated today and discharged day after tomorrow. So it's that fast. And the pain is not there. Maybe robotic plays a very important role in this as well. Because truly there is a very less dissection. Incision is small as well. So because of this also, this happens.
Thank you, madam.
Yeah, sorry.
Thank you, madam. It was nice discussion, a nice presentation.
Thank you so much.
Now let's go for the second.
Dr. Das, I have a comment. Can I say something?
Yeah, please.
Thank you, ma'am. Very nice lecture, and I really liked your idea of putting prilocaine before these.
Truly helps, Prana. Truly helps. Whoever can do it, please do it.
I just wanted to tell you that now LOX patches are also available, 5% patches. So maybe those also can be applied.
Yes.
I want that routinely we are leaving the adductor canal catheters for TKR surgeries.
Yes.
So we are practically not giving epidurals even for bilateral TKRs.
Yes.
So just with spinal and additive in the spinal, we are managing even bilateral TKRs, unilateral TKRs. We are giving adductor canal block, and we are leaving behind the catheter. And our pain nurses go every 8 hourly and give the top up there. And the patients are ambulated the very same day.
Perfect.
Not have any headache, post-spinal headache. And there's no urinary catheterization also.
Yes.
And some of the patients who have, say, problem of BPH or something, then the bladder is evacuated at the end of the surgery, and patients are very comfortable, and we are able to discharge them on the very next day.
Yeah. Good, great, very nice.
Thank you, everybody. Now, because of short of time, we will go ahead for the second lecture. Our second lecture is going to be given by Dr. Aditi Lele. She is from Nair Hospital. She has done her DA from Nair Hospital in 2010 and DND from PD Hinduja Hospital in 2013. She was a clinical associate in PD Hinduja as well as in Jupiter Hospital. She is more concerned about the neuro anesthesia and regional anesthesia. She is more interested into this. She will do a case presentation, emergency LSCS in a patient with sickle cell disease and thalassemia. Over to Dr. Aditi Lele, madam. Dr. Aditi, are you there?
Thank you, Dr. Das. I would like to thank SAMS and Thane ISA office bearers for giving me this opportunity. So it was a lazy Saturday and I got a call for emergency LSCS.
Your voice is not proper, madam.
I rushed to the hospital only to find that the patient was being wheeled inside the theater, a 26-year-old female with history of 38 weeks of amenorrhea, fetal distress, meconium positive. So, and well, emergency LSCS and they dropped the bomb with sickle cell disease with alpha thalassemia. So, there was absolutely no time or network to Google. I did a quick TAC. She had an uneventful ANC, history of lab call in the past, no allergies, no ICU admissions, had received blood transfusions sometime in the past. There was no active cough, cold, fever. She was NBM for more than 6 hours and hydroxyurea was withheld. She was on low dose aspirin and other supplements. On clinical examination, I found that her room air sats were 97%. She was pale. There was icterus and she had frontal bossing. Otherwise, she looked well preserved. Systemic examination, airway examination, spine were absolutely normal. Investigations, HB was 8.5 gram percent and her total bilirubin was raised. It was 3.4. Other investigations were okay. A written valid informed consent for regional anesthesia, SOS GA with post-op ICU care, SOS blood and blood product transfusion was taken. And I decided that my approach was going to be keep it simple, silly. So I decided to go with spinal anesthesia. And वैसे तो ऐसे cases हम यूं ही कर लेते हैं. Euvolemia, eucarbia, euthermia. So I just decided that my goal was going to be maintain the physiology of the patient. Inside the theater, minimal mandatory monitors were attached. I continued the RL drip which she was on. Under all aseptic precautions, I gave spinal anesthesia with 25 gauge Quincke's needle in L3, L4 interspace with 2.2 ml of 0.5% bupivacaine heavy. A level of T4 was attained. Post-air warmer was given to the patient. Surgery started, baby was delivered, handed over to the pediatrician and later shifted to NICU. After baby delivery, I gave a oxytocin 20 units and 500 ml RL drip. Vitals were stable. Blood loss, like normal, was about 1 liter. Urine output 150 ml clear. Losses were adequately replaced with Ringer's lactate. Post-operatively, vitals were stable. Spinal level of T6, T7 was attained. Patient was shifted to a high dependency unit for observation and later to the ward. On POD1, patient had a fever spike. Investigations were all normal except for HB, which was 6.8 gram percent. Antibiotics were continued. 1 unit PRBC was transfused. Hematologist had asked to start hydroxyurea, so we started that. On POD2, HB came to 8.8. So another unit was transfused on day 3. HB was 10 gram percent. Patient was absolutely stable and was discharged home. Now, why is it important to discuss this case? Most of us have done sickle cell anemia, or if not, we would definitely encounter it considering the fact that Maharashtra and Madhya Pradesh bear the highest burden of sickle cell disease cases in India. Sickle cell disease is a homozygous state with sickle cell hemoglobin or heterozygous with other abnormal hemoglobins like HBC, alpha thal, beta thal, HBO Arab, or so on. While sickle cell trait is only heterozygous HBS. I'm not going to delve into the pathophysiology right now. SCD has multiple systemic, acute and chronic clinical manifestations. Most common during pregnancy are painful vaso-occlusive and acute chest syndrome. So as you can see over here, there could be right from retinopathy to pulmonary hypertension to cardiomegaly, diastolic heart failure, liver dysfunction, renal dysfunction, splenic infarction. So like you name it, you have it. Now, why SCD is important in pregnancy? Because both of them have a reciprocal influence on each other and are associated with adverse maternal and perinatal outcomes. Though the incidence has decreased now with newer medications, SCD causes anemia, increased oxygen demand, circulatory overload, organ dysfunctions, as we have already seen. While physiological changes of pregnancy which affect this are procoagulant state, aortocaval compression, venous stasis, exaggerated anemia. So there is increased risk of sickle cell disease related complications like painful sickle cell crisis, acute chest syndrome, infections, while there is also increased risk of PIH, spontaneous abortions, placenta previa, abruption, placental insufficiency leading to IUGR or stillbirths, preterm delivery, puerperal infections, neurodevelopment delay. Also, they have an increased incidence of cesarean sections than the general population. These patients require multidisciplinary management. So it is better to have the obstetrician, hematologist, anesthesiologist, critical care expert, transfusion medicine specialist involved right from the beginning. The anesthetic evaluation. Now, this should ideally be done in the 3rd trimester as many of them go into preterm labor sometime around 34 weeks of gestation. Most of them should be offered to be induced around 37 to 38 weeks of gestation and should not be extended beyond 40 weeks of gestation as it increases the risk of sickling. So in pre-anesthetic evaluation, we should determine severity of SCD, the complications and extent of organ damage, history of ANC period like infections, transfusions, or any sickle cell related complications, past history of transfusions, ICU admissions, cardiac or pulmonary diseases, sickle cell crisis, infections, any other history of surgery, anesthesia, treatment history, hydroxyurea, ACE inhibitors, angiotensin receptor blockers, these should be stopped during pregnancy. Hydroxyurea is known for its teratogenic effects. Low-dose aspirin is started in these patients to prevent PIH. They may also be on low molecular weight heparins if there is a high probability of thromboembolic events. We need to know these because we have to time our regional anesthesia accordingly. So my patient, so we have to see the patient clinically and for organ damage and note the saturation on the room air. Airway and spine examination needs to be done. Investigation wise, obviously we'll see the hemoglobin. Typically it's between 5 to 10 gram%. Plasma urea, creatinine, urine dipstick test, liver function tests. Though the articles have mentioned chest radiograph, we wouldn't do it as a routine unless and until it is indicated. Pulmonary function test, blood needs to be cross-matched, extended analysis is required, so we need to have enough time in hand. Arterial blood gas analysis, ECG, echo if indicated, neurological imaging if indicated. Preoperatively, we would advise the patient to be NBM for 6 hours for solids. However, it is preferable to allow clear fluids up to 2 hours pre-op to avoid dehydration, and we can have a combination of oral and IV fluids. Written informed valid consent, arrangement of adequate blood products. As I said, it takes time. If preoperative blood transfusion is warranted, as in multiple pregnancies or hemoglobin is less than 7 gram%, it should be done ideally 14 days prior. If not, at least 24 hours prior to the surgery to utilize the increased oxygen carrying capacity. In high-risk patients, exchange transfusion wherein the hemoglobin HbS less than 30% is the target. However, this is rare. Incentive spirometry, chest PT is encouraged. Prophylactic antibiotics are given. Now, the general principles of management in these patients is maintain good hydration, oral IV. There is a recommendation of 60 ml per kg per day after correcting deficits and ideally give warm fluids, chest physiotherapy, incentive spirometry, antibiotics. Take care to avoid hypothermia, hypoxemia, hypovolemia, acidosis, hypotension, as all of these promote sickling. Analgesia and anxiolysis as required. Strict vigilance to watch for VOC, ACS, neurological changes. Be careful during positioning the patient because either they have a history of AVN of the hip or they might have undergone joint replacement surgeries. Maintain optimum OT temperature. Use forced air warmers wherever possible. Now, we might encounter a patient with SCD in labor. They have a very high chance of going into sickle cell crisis. Labor leads to increased oxygen consumption, blood loss, vasoconstriction. So gold standard here is central neuraxial analgesia. Epidural is ideal. Sympathetic blockade causes vasodilation, increased blood flow, and prevents a VOC. Epidural can also be used for labor analgesia to maintain pain in VOC, or if labor is protracted and LSCS is planned, then a top-up can be given and used for anesthesia. Other options include Entonox, which I believe we don't have here. Even opioids can be used, but remember to avoid pethidine as it can cause seizures in sickle cell disease. Maintain oxygen saturation above 94%. Supplement O2 if required. Patient with SCD for LSCS. Incidence of LSCS, as I mentioned, is higher than in general population. Both regional and general have been found to be equally good. How meticulously it is given is more important. In regional, we can give spinal, we can give CSE or pure epidural analgesia converted into anesthesia. It allows monitoring for sickle-related complications like chest pain, cough, and early detection would help to intervene better. General anesthesia, remember to give good pre-oxygenation, ramped up position, use HFNO if possible, and NM monitoring, that is neuromuscular monitoring, is essential, especially to ensure that relaxant has completely been reversed before extubation. Here in this table, we can see the advantages of GA regional and the disadvantages too. General anesthesia leads to less hypotension, better control of ventilation and oxygen, especially in sick patients, less anxiety, while disadvantages are relatively less analgesia, large blood loss considering the effects of anesthetic agents on the uterus, risk of failed intubation, risk of pulmonary aspiration. These come with obstetrics, post-operative sedation and hypoventilation. Regional anesthesia gives good pain control, low risk for thromboembolic events, less incidence of sickle cell crisis, less intra-blood loss, decreased risk of pulmonary aspiration. Vasoconstricting agents like ephedrine, phenylephrine can be used safely. Try to maintain BP above 90% of the baseline. Uterotonic drugs, oxytocin, bolus followed by infusion is safe. Carbetocin, sickle cell disease is not an absolute contraindication, but it should be avoided in seizures, preeclampsia, and renal impairment. Methergine, ergometrin, avoid in preeclampsia and pulmonary hypertension. Prostaglandins, use with caution due to bronchospasm. Major obstetric hemorrhage. Hypercoagulable state, this is quite a possibility. Blood transfusion is required. Replace blood with blood. If you have fully cross-matched units, nothing like it. If not, use the least incompatible units. Under the cover of IVIG and methylprednisolone, involve the transfusion medicine specialist and hematologist stat. Tranexamic acid can be used as usual. Caution in renal dysfunction. SCD is not a contraindication to cell salvage, but use in obstetrics is not documented much. Post-operative pain management. Essentially, it is multimodal. You can use oral or IV paracetamol, NSAIDs, opioids except pethidine. Low-dose ketamine can also be used. Epidural analgesia, local anesthetic agents or low-dose opioids. Regional blocks like bilateral or transversus abdominis plane block or ilioinguinal iliohypogastric nerve block can be used. Patient-controlled analgesia, both IV or epidural, have better results. Post-operative concerns. Consider a high dependency unit or ICU at a lower threshold. Monitor temperature as fever is an early sign of sickling. Watch for sickling related complications, VCO, ACS, stroke, etc. Blood transfusion, your target hemoglobin should be 10 gram%, but not more than 4 gram% at a time. Maintain hydration. Thromboprophylaxis, mechanical or pharmacological, and early mobilization. These help. Thromboprophylaxis should be continued for 7 days after normal vaginal delivery and up to 6 weeks after LSCS. Chest PT, incentive spirometry to be continued, antibiotics to be continued. Restart hydroxyurea as per hematologists. These are my references. I would be happy to share with those who want to go through them later. Thank you so much for a patient hearing.
Thank you, Madam. Dr. Aditi. It was a nice presentation. Till now, I have not seen any question till now. If some question will arise, then I will ask you again. It was a nice presentation. Now our next guest lecturer is Dr. Hetal Badedra. He is a senior anesthesiologist. He is practicing since 2000, and now at present he is HOD of the Department of Anesthesia in Sterling Hospital, Rajkot. He started his freelancing practice in 2000. Up to 2009, he did the freelancing anesthesia. After that, from 2010, he is attached to Rajkot Sterling Hospital. Now he is HOD in anesthesia department. His clinical interests are regional anesthesia, neuro anesthesia, and bariatric anesthesia. His good thing is his special interest is creating awareness about the CPR in the public. He is a mentor in EORA fellowship program, and he is GRAS Education Initiative Award. He has got that GRAS Education Initiative Award in 2018. He is having 6 publications about RA, and he is invited to so many state level and national level conferences as a faculty in conferences as well as workshops. Now, today he will talk about the anesthesia for breast surgery, how he does, how I do it. This is his lecture today, anesthesia for breast surgery. And with this, I am giving over to Dr. Hetal. Dr. Hetal, please start.
Yeah, thank you for the kind introduction, sir. First of all, I would like to thank Thane Society of Indian Society of Anesthesia and Maharashtra Society of Indian Society of Anesthesia for inviting me for this talk. I'm going to speak on anesthesia for breast surgery, how I do it. But actually, I will talk about why I do it rather than talking about how I do it. So in my talk in next 40 to 45 minutes, I will talk about breast cancer statistic, type of breast surgery, anatomy of the breast, how we do pre-op assessment, intraoperative, how we manage it, regional anesthesia option, this is very important for breast surgery, post-op management, breast surgery and chronic pain, and type of anesthesia and cancer recurrence in the breast surgery. So if you look at the cancer statistic in 2020, there were 2.3 million women diagnosed with breast cancer, and there were 6.85 lakh deaths globally. So as of the end of 2020, there were 7.8 million women alive who were diagnosed with breast cancer. Dr. Alkesh, can you please mute your mic? Yeah. There were 7.8 million women alive who were diagnosed with breast cancer in the past 5 years, making it world's most prevalent cancer. If we look at the data in the India, incidence is quite high. It is roughly 1.62 lakh women who are newly detected every year, and that is 27.7% of all newly detected cancers among women. And if you look at the mortality rate, again, it is roughly 24% in India of newly detected cancers in India. So if we talk about type of surgery, there are various surgeries like axillary lymph node dissection, sentinel lymph node biopsy, MRM, breast conservative surgery, simple mastectomy, reconstruction surgery, and cosmetic surgery. So for different surgery, we need to go for a different option of anesthesia, and there are different challenges. So when surgeon opt for axillary lymph node dissection, we should think about postoperative lymphedema, upper limb sensory loss, and prolonged stay because of there are drains and there is lymphatic drainage through the drains. So now they are moving from sentinel to the sentinel lymph node biopsy. So sentinel lymph node is the group of lymph node that drains from the primary cancer and is therefore most likely to contain metastatic disease. So in sentinel lymph node biomapping, they usually carry with a combination of radioisotope and dye injected near the tumor during the surgery for removal of the primary cancer. And the lymph node with the highest radioactive signal will be removed. So they don't need to do complete axillary dissection, but they do dissection of the 3 or 4 lymph nodes, which are highly sensitive for the radioactive signal. But there is again challenges. They use isosulfan blue or patent blue dye. They are associated with immunoglobulin E mediated anaphylactic reaction. Incidence is mild, that is 1%. For mild reaction, that is 1%, and for serious reaction, it is 0.17%. So it is a quite high incidence. So whenever you find any hypotension or any allergic reaction response, hemodynamic response, you should think about anaphylactic reaction when they are doing sentinel lymph node biopsy, and accordingly, you should treat the patient. BCS, simple mastectomy and MRM. In this surgery, we should look about duration of the surgery, incision, and dissection. Accordingly, we have to plan the regional anesthesia option, which we will discuss in the further slides. And if duration is prolonged, we should think about the fluid replacement. We should think of temperature management, and we should think about anesthesia management also. Reconstruction surgery, mostly they do either myocutaneous flap or free flap. Free flap surgery are quite long surgery, like they take 6 to 8 hours for free flap surgery. And in this surgery, we have to think about maintaining proper perfusion in the flap. If patient is in hypotension or hypovolemic or hypothermic, then there are chances of flap failure. So we should consider this thing. Another important point, when the surgery is prolonged, we should think about giving DVT prophylaxis to the patient. So if surgery is prolonged, we should go for pneumatic compression devices, as well as we should go for pharmacological prophylaxis with low molecular weight heparin. Cosmetic surgeries done are like mammoplasty. It's similar to the mastectomy or prosthetic implant. Prosthetic implant, sometimes it is done in 2 stages. Initially, they put the implant below the pec major muscle. Then gradually they expand the implant so that they can create the space. And in second stage, they put the real implant. So these are the painful surgery, and sometimes they lead to chronic pain in the patient. So you have to provide proper analgesia to prevent the chronic pain, and you should treat the pain. When patient comes for the breast surgery, obviously they are very anxious. They are worried about the malignancy. They are worried about the cosmetic component. They are worried about the anesthesia part. What will be the type of anesthesia? They are worried about the post-operative pain management, intraoperative pain management. So it is very important to discuss everything with the patient. Give some time to the patient when they come for pre-op assessment. Talk about plan of anesthesia, talk about regional anesthesia management, talk about pain management, and reassure the patient so that the anxiety can be reduced. And if required, we can give pharmacological and anxiolytic drugs. When patient is on chemotherapy or radiotherapy, when tumor size is more, they go for chemotherapy in the preoperative period. Chemotherapeutic agents sometimes cause some cardiac toxicity. So we should go for echocardiography and ECG irrespective of age of the patient when they are on the chemotherapy, because they can cause sometimes cardiomyopathies in the preoperative period. They start neoadjuvant hormonal therapy also. It is used to reduce the size of the locally advanced tumor and make initially inoperable cancer more amenable to resection. It can cause myelosuppression, which may manifest as perioperative anemia, increased bleeding tendency because of thrombocytopenia, and neutropenia, which can lead to increased chance of infection. So if a patient is on neoadjuvant therapy, we should keep this thing in mind. We should be prepared for the blood loss. We should be prepared for the post-operative infection, and accordingly, we should start the antibiotics. If patient is on tamoxifen or aromatase inhibitors, that can lead to cardiotoxic toxicity or that increase the risk of perioperative venous thromboembolism. So if patient is on these drugs, then we should start thromboprophylaxis early so that we can reduce the chance of venous thromboembolism. Anesthesia management, there are various techniques used like TIVA versus inhalation. There is a ongoing debate about TIVA versus inhalation, where they compared the outcome of after breast surgery between inhalation and propofol-based intravenous anesthesia. And what they found was with TIVA, postoperative rescue antiemetic drugs are reduced. Propofol-based intravenous anesthesia preserve natural killer cell cytotoxicity. It decreased IL-6 level and neutrophil to lymphocyte ratio and increased 2-year recurrence-free survival, but did not affect the recurrence of the overall survival rate. So we don't know exactly whether it helps or not, but there are few studies which support that it helps to reduce the chances of recurrence, but there is no enough evidence. Opioids versus opioid-free analgesia. Again, opioids were considered to increase the chances of recurrence. So there is debate between using opioids for this surgery versus doing opioid-free analgesia. But again, there is no robust evidence which says that opioid can increase the recurrence rate. Regional anesthesia, it is always part of anesthesia management, whether you do solely under regional anesthesia or it can be used along with GA for intraoperative and postoperative pain management. Some important points while giving anesthesia in this patient, like IV lines, it should be taken on the opposite side of the surgery. It should not be taken on the same side because it usually surgeon keep the arm abducted while doing the painting and draping because they want to do axillary lymph node dissection. And another important point is if lymphedema, it can increase the chances of, initially it was believed that it can increase the chances of lymphedema, but again, evidence is not supportive. Airway management, it is important. If it is surgery like only MRM or mastectomy, you can go with iGel or whatever supraglottic airway device you're using. But when they are doing surgeries like LD flap or prolonged surgery like free flap, it is better to secure airway with endotracheal tube because sometimes they change the position and there are chances that you lose the airway during the surgery. Position of the patient, as I said, it can be changed in the patient with LD flap surgery, but in remaining surgery, it is supine position with abducted arm. So you should be careful not giving over abduction because it can stretch the brachial plexus and sometimes it can cause injury to the brachial plexus. Combination of RA and GA is the best. If you combine both the technique, you can reduce the requirement of general anesthetic and you can provide a postoperative analgesia to the patient and you can give good hemodynamic stability intraoperatively. Hypothermia, hypovolemia, it should be avoided in all patients, but it is very important, especially in the patient with free flap surgery, because it can lead to vasospasm and failure of the flap. Blood loss, usually nowadays it is not much seen in the breast surgery, but it can happen in the surgeries like free flap surgery. And if a patient is on, as I said, on the chemoadjuvant therapy, they might have thrombocytopenia. In such patient, we should be ready with bloods and blood product. DVT prophylaxis, it should be done with either pneumatic compression devices, and whenever required, we should go for low molecular weight heparin. Regional anesthesia, this is most important part of the presentation, so we'll go into the detail. First, we'll talk about anatomy. If you look at the anatomy of the breast is supplied mainly by thoracic nerve. So once they come out of the intervertebral foramen, intercostal nerve get divided into ventral and dorsal root. Dorsal root supply the skin over the back, while ventral root travels in the intercostal space as the intercostal nerve. It gives lateral cutaneous branches at mid-axillary level and anterior branch of the lateral cutaneous branch supply the breast. It goes further ahead in the parasternal area. Again, anterior cutaneous branches come out, and it divides into medial and lateral branch, and lateral branch supply the breast tissue. Intraclavicular region is supplied by the supraclavicular nerves. That is part of the this is supraclavicular nerve. That is part of the superficial cervical plexus. And if you look at the nerve supply of the muscles of the breast, it is supplied by lateral pectoral nerve, medial pectoral nerve, and thoracodorsal nerves. They are again part of brachial plexus. So breast is complex innervation, which is from superficial cervical plexus, brachial plexus, and thoracic nerve. So here you can see these nerves, these muscles are supplied by the thoracodorsal nerve, long thoracic nerve, and the pectoral nerves. So if you look at the anatomy, here you can see this is pec major muscle. If I remove the muscle, you can see this is pec minor, and above that you will find the lateral and medial pectoral nerve. So when you give PEX1 block, you deposit the drug between these two muscles, and you will end up blocking both these nerves. If you go further laterally, you will find the serratus anterior muscle, and this is the long thoracic nerve. This is long thoracic nerve, and if I remove it, you will find the lateral cutaneous branches emerging through the serratus anterior. These are the lateral cutaneous branches. So if you deposit the drug between these two muscles, it will block the lateral cutaneous branches as well as the long thoracic nerve. That is your PEX2. If you go further posteriorly into mid to posterior line, you will find the latissimus dorsi muscle. And in between the latissimus dorsi and the serratus anterior, you will find the thoracodorsal nerve as well as the lateral cutaneous branches. So if you deposit the drug there, it becomes your SEP block. There are two types of SEP block, superficial as well as deep block. Superficial is between latissimus dorsi and serratus anterior in the mid to posterior line, while deep block is between the ribs and the serratus anterior muscle. So there are different options for blocks. Like you can start from thoracic epidural, you can give paravertebral, they are gold standard. Erector spiny block, it is emerging block, and it is used for XYZ, all type of surgery. You can use it for any type of surgery. Literature is flooded with article about erector spiny block. You can give intercostal nerve block, you can give PEX1, PEX2, SEP block. So these are various blocks which can be used for breast surgery. Thoracic epidural, it is an age-old technique. It provides bilateral analgesia, and you require less amount of LA. But at the same time, the disadvantage is it is a too invasive, and it is contraindicated in the patients on the antiplatelets as well as on the anticoagulants. And there are some hemodynamic changes. So it is not preferred nowadays because there are many options of regional anesthesia. Thoracic paravertebral block, it is basically depositing the drug in the wedge-shaped paravertebral space. It is bound anteriorly by the pleura, posteriorly by the superior costotransverse ligament, and medially by the vertebra and the component of the vertebral body. So if you deposit the drug here, it will block posterior dorsal division as well as the ventral division of the intercostal nerve. And when you inject the drug in the paravertebral space, like here, it will spread cranially as well as caudally. Sometimes it spreads up to 1 to 2 segment, and sometimes it stays there. It also spread medially towards the epidural space, and it spread in the intercostal space also. So drug can spread in the all direction, but it varies from patient to patient. Sometimes it spread up to 3 to 4 segments, while sometimes it stays there. That's why when you are using for surgical anesthesia, especially with landmark guided technique, you should give multiple level blocks to give complete surgical anesthesia. If you compare the ESB to thoracic paravertebral, it is very simple. This is a schematic video where I will show what is ESB as compared to thoracic paravertebral block. So if you this is roughly at T4 T5 space, you will find trapezius, rhomboids, and erector spiny muscle. This is the transverse process. So if you hit the transverse process and deposit the drug in the plane in between, it becomes your erector spiny block. It is a facial plane block, and with single injection, drug will spread. While with thoracic paravertebral block, you hit the transverse process, you walk up the transverse process and deposit the drug in the thoracic paravertebral space posterior to the superior costotransverse ligament and anterior to the superior costotransverse ligament, posterior to the pleura. That will push the pleura anteriorly. So, as I said, with landmark guided technique, you have to palpate the C7 transverse process, spinous process initially, then mark T1 to T6, go 2.5 centimeter lateral to the spinous process, insert the needle perpendicular to the skin, hit the transverse process. Transverse process lies at different depth in different patient. Even in same patient, at different level, it is at a different depth. So you have to hit the transverse process first, then walk up the transverse process. You should go 1 to 1.5 centimeter beyond the transverse process. You will feel some click of superior costotransverse ligament in some of the patient, while sometimes you miss it. Even if you miss it, deposit the drug at 1 to 1.5 centimeter beyond the transverse process, and drug will spread in the thoracic paravertebral space. When you are doing blind technique, it is prudent to go at multiple levels so that you get good analgesia. But if you have ultrasound, you inject the drug and you can check the spread in the cranial and caudal spaces. If it is spreading nicely, you can go with a single or two injection. And if it is not spreading, you can give multi-level block. So again, this is the spinous process. You go 2.5 centimeter lateral to it, hit the transverse process, walk up the transverse process, and inject the drug. For ultrasound guided block, this is the technique I'll show step by step. Here you can see this is the patient, this is the transverse process, this is the pleura, and this is the superior costotransverse ligament. You can give it with out of plane or in plane technique. Your needle come from here. I am giving out with out of plane technique in the parasagittal view. You can give even with transverse view also. So you can see my needle is coming here. You can see the pleura is getting pushed after injecting the drug. And after injecting the drug, you can check the spread also. You can see drug is spread in the cranial or upper space, and you can see the spread in the lower space or the caudal space to confirm the good spread of the drug. So after thoracic paravertebral, you will ask why ESB came when we have thoracic paravertebral block. ESB is a simple, it is easy to perform, and you can give it with or without ultrasound. It has lesser or minimal incidence of pneumothorax and hypotension as compared to thoracic paravertebral block. So when you inject the drug for ESB, you basically hit the transverse process and you inject the drug in this area. So when you inject the drug here, initially we were thinking that through this nerve root where it pierces the superior costotransverse ligament, this drug will slowly go inside the thoracic paravertebral space. But nowadays it is proved that there is a gap in the superior costotransverse ligament also. So drug will seep into the thoracic paravertebral space through this gap, and it will go into the thoracic paravertebral space, and it will block the ventral root as well. It will definitely block the dorsal root. But if you see here, if you deposit adequate amount of the drug, some of the drug will definitely go into the thoracic paravertebral space. Another theory recently in the recent regional anesthesia pain medicine article, they say that it affects the dorsal root ganglion also, and that is the probably reason for good analgesia even without sensory loss in the erector spiny block. Sometimes you have given the erector spiny block, you check with the needle prick, you will not get good sensory block. But patient will have some pain relief. That is because of the spread of the drug toward the dorsal root ganglion, and it provide analgesia. So this is the research were coming in for the erector spiny block. Previously, it was thought that through costotransverse foramen drugs seep into the paravertebral space. So there are many theories which are coming up to explain the effect of erector spiny block, and in future it may replace the thoracic paravertebral block. But at present, I believe that thoracic paravertebral block is gold standard and it provides definite analgesia, while erector spiny block sometimes it doesn't provide analgesia at all. So if you look at the video, this is the transverse process. My needle is coming in plane. These are the three muscles of the back, trapezius, rhomboid major, and erector spinae. I'll hit the transverse process and inject the drug, and drug will spread in the plane, that is erector spinae plane. After erector spinae block, we will talk about PEX1, PEX2, and SEP block. In PEX1, there are pectoral nerves, that is lateral and medial pectoral nerve, while in PEX2, you block T2 to T6 along with the PEX1 block, and in SEP block, you block the long thoracic nerve, thoracodorsal nerve, and T2 to T9. Indication, you can use PEX1 block for surgeries like insertion of breast implant, pacemaker, or portocath insertion. PEX2, it is used for MRM and axillary dissection, while SEP block can be used for more lateral incisions like LD reconstruction, and you can use it for multiple rib fracture. You can put the catheter in the SEP plane, and you get good analgesia for anterior rib fractures. Now block with PEX1, as I said, with PEX1 you block LPN and MPN. With PEX2 you block T2 to T5 and long thoracic nerve. And with SEP you block thoracodorsal and intercostal nerve, that is T2 to T9. You block lateral cutaneous branches of intercostal nerve in all these blocks. You don't block anterior cutaneous branches. For PEX2 you require 10 ml of LA. For PEX2, usually 20 ml of LA required because you want to block T2 to T6, while for SEP, you require 20 to 25 ml because it blocks T2 to T9. So if you do the scanning, you start the scanning from clavicle at the mid-clavicular line. You can see this is clavicle. You can see axillary vessels. If you go down, you will find the pec major muscle, this pec minor, and these are the ribs. You have to tilt the probe medially to see the rib. If you keep the probe perpendicular to the skin, you will not able to see the rib properly. You little bit angular medially, and you will find the ribs. You will find this pectoral branch of thoracoacromial artery between these two muscles. If you will find it, and if you deposit the drug here, you will definitely block lateral pectoral and medial pectoral nerve. While for SEP block, this is the serratus anterior muscle. This is a very thin strip in the at the level of anterior to anterior axillary line of the serratus anterior muscle. So you deposit the drug between pec minor and this serratus anterior, and it becomes your PEX2. So this is for PEX1 and this is for PEX2. So you require 2 injection, but you should give PEX2 block. Initially, you should deposit this drug between PEC minor and SA initially, then go for PEC1 block, because once you deposit the drug in the deeper plane, it will lift up the muscle. But if you deposit the drug here first, then it will depress the muscle, and it is difficult to visualize the needle. This is for SEP block. You find the LD and SA in the mid to posterior line at the level of 5th and 6th rib. You can deposit the drug at this plane. This is superficial SEP block, and this is the deep SEP block. So if we look at the video of the PEX1 and SEP block, so I am using either PEX1 and PEX2, or I use PEX1 along with the SEP block for breast surgery to provide analgesia. But PEX1, sometimes surgeons are reluctant because drugs comes in their plane and they don't want to go through the tumor part to prevent the spread of the tumor. So here you can see this is the rib. I am moving the probe caudally, and you can see the rib and pec major and pec minor muscle. Once I go down, you can see this is the thoracoacromial pectoral branch of the thoracoacromial artery. You can see the pulsation here. So if you deposit the drug here, this is the scanning part. It becomes your PEX1, and if you deposit the drug here, it becomes your PEX2 block. So after doing this scanning, you can go here. You can see my needle is coming in plane. Here I deposit the drug first between PEX1 and PEX2 because I am giving PEX1 along with the SEP, so I can do it. But if you are doing PEX1 and PEX2, you should go for PEX2 first and then PEX. Here you can see I'm manipulating my needle near the vessel, and I'm depositing the drug for a good spread. Initially, some of the drug has gone intramuscular, but now I'm positioning the needle for the better spread of the drug. So this is how you can give PEX1 block. For SEP block, again, These are the fifth and sixth rib. This is the LD muscle, while this is the step muscle. Step muscle is thicker at this level. So my needle again coming in plane. It is coming from this side of the screen. You can so this is from anterior to posterior. I'm advancing the needle, and I will try to deposit the drug between two muscles. That is superficial step block. So here you can see I'm trying to deposit the drug between two muscles. So with this, you can give a step block. PEX 1 and PEX 2, I will skip the PEX 1 part, and this is PEX 1 again, and we will move to the PEX 2 part. Here you can see I'm coming in plane for between serous anterior and PEC minor, and you can see my needle. You can see my needle. Always look for the needle tip before injecting the drug, because you are very close to the pleura, and always attach syringe to the extension tubing of the needles, so that even if you puncture the pleura, it will not suck the air, and you can prevent the pneumothorax. It is true for thoracic paravertebral block also. So this is how you can give PEX2 block. For medial cutaneous branches, you can give either pectoralintercostal plane block, or you can give transverse thoracic muscle plane block. PIP block is basically superficial. You can deposit the drug between the pec major and the costal cartilage. If you go deeper between intercostal muscle, at this level, it becomes your transverse thoracic muscle plane block. But it is recommended to go superficial block. It provides similar analgesia with less chances of complication, because here you are very close to the internal memory artery and you can puncture it. Supraclavicular nerves, as I said, you require some local infiltration to complete analgesia. You have to infiltrate 3 to 5 ml of LA just above the clavicle, superficial to the clavicle, and it will take care of supraclavicular nerves. So after looking at this ultrasound guided blocks, the question comes to our mind is, can we give with landmark guided technique or PNS? Yes, we can. So this is LRESB. It is very simple. You need to just go 3 centimeter in the palpate T5 spinous process, mark a point 3 centimeter lateral to insert the needle, hit the transverse process, and deposit the drug. Why we do it? Because we want to deposit the drug at the tip of transverse process, so that it spread to the thoracic paravertebral space, to the costal transverse foramen, or through the supercostal transverse ligament. So we have to go to tip of the transverse process. You just hit the transverse process and deposit the drug. Once you hit the transverse process and deposit the drug, we will check the ultrasound spread. You have to always aspirate before injection, because all this area is vascular area, and you can do local anesthetic systemic toxicity if it goes intravascular. So after injecting the drug, we did the ultrasound confirmation, and you can see these are the transverse processes, and you will see the drug spread. This is the drug nicely spreaded over the transverse process and below the erector spinae muscle. So with this, you can see, you can very easily give the erector spinae block. In fact, in all our spine surgery, we give the erector spinae block blindly only, and without any complication, and with very good analgesia. Landmark guided paravertebral block, again, it is very easy. This was the case of nephrectomy. This was thin and lean patient, so we are inserting the needle at T8 or T9 level. You can see we have hit the transverse process. After hitting the transverse process, we are walking up the transverse process. We are going caudally, and you can see at 3 centimeter we hit the transverse process, and at 4 centimeter we got the loss of resistance. And when we started injecting the drug, you can see drug is nicely spreading in the thoracic paravertebral space. So this is how you can give with landmark guided technique. PNS PEX1 block, again, this is a very nice block with PNS technique. You have to go between mid to mid clavicle line to the anterior axillary line. You have to go at the fourth rib, and you can see the contraction of the pectoral muscle. When you give intraclavicular block, you must have seen similar contraction. So you have to look for the contraction at 0.5 milliamps, otherwise it might be a muscular contraction with the stimulation. So if you stimulate the nerve, you get the contraction at 0.5 milliamps. You can see the contraction at 0.75. I'm reducing the current further, and you can see the contraction at 0.5 milliamps. And these are all live demonstrated on Facebook group tasks. These were demonstrated live. so that people have faith in this technique. Again, this is the PNS guided SEP block. This was a quite obese patient, and you will see how easy it is. This is between mid to posterior line at the fifth or sixth rib level. I'm looking for the serratus anterior contraction, and you can see the contraction very well here. You can see the contraction. I will reduce the current, and you will see the spread of the drug. So I'm reducing the current to 0.5 milliamps. Once it is done, we can inject the drug, and after expiration, you inject the drug, and you will have a nice spread of the drug in the SAP plane. This is LOR PAX2 block. Again, this is very simple block. It can be given with landmark guided technique. You have to palpate third or fourth rib. You go between the mid clavicular to mid anterior axillary line. Initially, I hit the rib. I am locating the rib. Once I got the rib, you can see I attach the syringe to the needle, so that I don't go inside. Even if I puncture the pleura, my air will not get inside the pleura, and there won't be any pneumothorax, or very small. There will be only small. So once I hit the rib, I will withdraw the needle, and I will look for the loss of air. This is blunt tip needle. By rubbing it inside the sterile bowl, you can make it blunt. So once I got the second resistance, I injected the drug, and then I again hit the rib and injected the drug. And when I check the spread, you will see, when I check the spread, the drug was nicely spreaded. You can see this is pec major and this is pec minor. You can see the drug between these two. And here you will see the drug between serratus anterior. This is the drug. This is serratus anterior, and this is pec minor. So this is how you can give it with landmark guided technique. Same way you can give SEP block with landmark. You have to simply hit the rib, because you want to deposit the drug between serratus anterior and rib. So you simply hit the rib and deposit the drug, and drug will here you can see I have marked the mid and posterior axillary line. I will go in between at the fifth or sixth rib. So I have palpated it. It is a quite obese patient, so I took a little bit of time to locate the space. You can see this is a live video. So once I hit the rib, you can see I am trying to find the rib. So once I hit the rib, I will deposit the drug, and it will spread in the plane. So this is how you can give it a landmark guided technique, SEP block. But question comes to our mind whether there is any evidence for this landmark guided technique or PNS guided technique. Logically, that is fine, but we need some evidence before start practicing it. So this is serratus anterior plane block with anatomical landmark guided technique. This was a letter to editor published long back in 2020. Then this was a study done in a college by a team. After this initial letter to the editor, they did a study, and they used the ejector spiny block with landmark guided technique. Then this is peripheral nerve stimulator guided serratus anterior block by Dr. Ritesh Roy, Dr. Shiv-Kumar Singh, and Dr. Gaurav Agrawal. Again, this is PNS guided PEX1 block with the same team. But before start practicing it, we should not forget that these blocks are part of multimodal analgesia, because they provide somatic pain relief only. So if you are practicing for breast surgery, that is fine. But if you want to practice it for surgeries like thoracic surgery, you should use other drugs also. And these blocks are high volume blocks, so we should calculate the toxic doses, and then only we should go for it. Ideally, speaking, either 0.2% propivecine or 0.25% propivecine, bupivacaine is enough to provide good analgesia. Thoracic segmental spinal, this is the talk of the town these days. Everywhere people are talking about thoracic segmental spinal anesthesia. You can use it for breast surgery as well. You use isobaric drugs, but personally speaking, I haven't used ever for breast surgery. I've used for other surgeries, but not for breast surgery. Yeah, but and evidence is coming up. You can use it if you are convinced with it. Prospect guideline for onco. Prospect is basically procedure-specific guidelines. They collected the data and prepared for specific surgery. So for minor breast surgery, they recommend that you should use in the preoperative period. We can start paracetamol and conventional NSAIDs or COX-2 inhibitors. We can start gabapentin. It provides good analgesia intraoperatively, and it may prevent chronic pain. Dexamethasone should be the part of multimodal analgesia, and local anesthetic wound infiltration can be enough for minor breast surgery. And in the postoperative period, again, we can use combination of paracetamol with NSAID or COX-2 inhibitor, and opioid should be used as rescue. For major breast surgery, we should add PEX block. Paravertebral block is the evidence, but if you don't want to give paravertebral block, or if it is contraindicated, then we can go for PEX block to provide analgesia. And again, you can use local anesthetic wound infiltration also. In the postoperative period, you can add continuous paravertebral block if you have put the catheter inside. We are moving to the last part of the presentation, that is post-mastectomy pain syndrome or chronic post-surgical pain after breast surgery. It can occur after breast surgery. Incidence is quite high. It occurs in 20 to 50% of the patient, but in our country it is underreported because people think that it is common to have pain in the postoperative period. Regional anesthesia may prevent chronic pain. There was a study where they thought that if we give regional anesthesia, it will lead to nervous system remodeling and it can prevent the chronic pain. But when they do prospective trials, it cannot be proved. Anti-inflammatory drug can be used for primary hyperalgesia, while RF for the secondary hyperalgesia. But we should use multimodal analgesia. It at least help in the acute pain relief, and if at all, it can help for chronic pain also. Paravertebral block for prevention of chronic post-surgical pain, they found that it can be CPSP can significantly prevented by paravertebral block after BCS, despite limitation into that surgery. So there are limitations in the surgery. Acute pain, it is yes, but chronic pain, it is again a question. Last part is anesthetic technique for recurrence of the breast cancer. Before 10 years, they thought that regional anesthesia, if you use regional anesthesia, if you don't use opioid, if you don't use inhalation agent, we can reduce the breast recurrence. They came with the evidence with retrospective study, but when they go for a multi-center prospective trial, it was not evidence was not much found. There was not much difference. But what they were thinking was, when you do a surgery and when you use volatile anesthetic, it will lead to activation of hypothalamus pituitary adrenal axis, and it will stimulate the sympathetic nervous system also. That will lead to stimulation of the neuroendocrine mediators, and that will lead to suppression of the cell-mediated immunity, and that may lead to the tumor growth and distant metastasis and recurrence. Opioid can stimulate it, while regional anesthesia can suppress it. Again, total intravenous anesthesia also suppress it. So it reduces the. So this is the basic hypothesis behind this study, but it is not proven yet. So this is again, we have discussed earlier that comparison of outcome after the propofol-based versus inhalation analgesia, but long-term benefits are not found. Last part is how I do it. So in pre-medication, we usually use fentanyl, that is single shot fentanyl. Either it is 1 to 2 microgram per kg, along with dexmedetomidine. We usually give single shot dexmed. Our surgeons are quite fast. They complete the breast surgery into 1 to 1.5 hours. So we just give 50 microgram of dexmedetomidine, and it helps tremendously to help the hemodynamics during surgery and reduce the blood loss. I usually prefer endotracheal tube as compared to eye gel. Because in the draping, sometimes eye gel get dislodged and you lose the airway. So I prefer endotracheal tube. I use sevoflurane in all my cases. After giving thoracic paravertebral block, of course, requirement of sevoflurane is quite less when you use dexmedetomidine along with thoracic paravertebral block. I like thoracic paravertebral block because it provides excellent analgesia along with very good hemodynamic stability. Some hypotension is very good for surgeon because it helps to prevent blood loss. And another important part is when we give PEX block or SEP block, drug will seep in their field, and some of the surgeons don't like it. And of course, multimodal analgesia is important. We use dexamethasone in all our cases. It helps in the prolonging the effect of the block, and it helps in the preventing nausea and vomiting also. So this is our routine protocol. We induce the patient. We give opioids with dexmedetomidine as pre-med. We induce with propofol and atracurium, ET, sevoflurane, thoracic paravertebral block, and multimodal analgesia. So to conclude my talk, the prevalence of breast cancer is increasing all across the globe. Surgery can involve the primary removal of the lesion and reconstruction. Preoperative assessment is paramount for allaying anxiety and identifying potential intraoperative issues because patient might be on the chemotherapy or patient might have other comorbid conditions. So we should take care of all those things. Pectoral blocks and SEP block provide good analgesia for daycare procedure, but I'll say thoracic paravertebral block is the gold standard. And ongoing research is in investigating anesthetic technique and their effect on cancer recurrence. It is still going on, but there is no robust evidence. So this is all about breast surgery. Thank you. Thank you very much. If you have any question, please.
Thank you, sir. It was a nice presentation. There are some questions like that 50 microgram dexmedetomidine what you are giving. So for how much time it will remain, or how much before how much time you are giving?
Usually we start 10 to 15 minutes before induction. So by the time a surgeon goes for the incision after painting and wrapping, we complete the 50 mics of dexmedetomidine and we have good effect of dexmed.
Oh, thank you, sir. There are only one question. Here I can throw some light. The pre-medication, if at all, we can give pregabalin or gabapentin 1 day prior to the surgery, and we will continue post-operative also. Then chances of your phantom breast that become less.
Yes, sir.
And the after surgery, because I get the patients after post management, post operation after 1 month or after radiotherapy, there the neuralgic chances are neuralgia chances are very much. So if at all we can start this before surgery, then chances of neuralgia pain is less.
Right, sir.
And they may develop, most of the people, around 20 to 30% people, they develop this CRPS. This is either sometimes it is transient period or sometimes it remains for a long time, which remains unnoticed. So if at all we will start this particular molecule before orally, these are given orally, then that helps in this CRPS. It prevents the CRPS.
Right,
Okay.
sir.
And thank you, sir. I am glad to say you that your techniques are excellent and your digital excellence is also superb.
Thank you, sir.
Nicely you present with your cutting edge of this digital tech, these things. What are the software you are using? Nice software.
It is basically on the MacBook. There is a video editing the app, so you can use it. And there are other apps also, but I use MacBook for it.
Very good, very good. Thank you, sir. Any question from anybody in this?
We have Dr. Shivkumar Singh with us, so we would like comments from him. Even Dr. Mulgaonkar is there.
Yeah, senior anesthesiologist are there.
So they are
Hi, Farhan, what do you want to know? Somebody is giving a live comment.
Mr. Ganesh, please mute everyone. Yes. Welcome, Dr. Shivkumar Singh. Sir, we would like your inputs and your technique. We would like to know about your techniques also.
In what? For TKRs, for breast surgeries? Because
Yes.
I do all of these. So,
Yes, regarding these two topics.
well, for TKRs, it depends on whether you're going to use spinal anesthesia or it's going to be GA. For GA, it is going to be multiple blocks. And I can tell you with great certainty that with the blocks, we don't actually, with multiple blocks, we don't require, I have not used opioids in any of our cases. And for spinal, it doesn't matter. You can actually give local infiltration analgesia if a surgeon is good at that. And blocks, just add only maybe partially to it. But what is most important is that if the patient is going to have general anesthesia, then you need to give multiple blocks. It's not just adductor canal block, it's just one of the blocks for total knee replacements. There are a lot more blocks involved. If you want to learn, there's a whole lecture on that. We can talk about it. As far as breast surgery is concerned, as rightly mentioned, depends on what the surgery is. It's very important to know what the surgery is, what the surgical anatomy is. Depending on that, you will likely cater to your block. PEC 1, PEC 2 have already almost gone out of fashion. They're not liked by surgeons, not because the local anesthetic or your needle can cause the tumor to be metastatic, but it is because if you have local anesthesia in this plane, when cautery is used, the local anesthetic is dissociated and it forms an ionic current. And the surgeon keeps telling my cautery is not working and I need to use higher currents. So they don't like local anesthesia in those planes. So we have moved away from that. Erector spinae block still remains, I think, one of the commonest blocks, though there are actually people who think that erector spinae block doesn't work. Some of the so-called experts keep arguing about it on the Twitter, but I think in real practice they do work. But why those blocks like PECs block don't work is because you do not actually catch the anterior cutaneous nerves, and you will get a response for it. So we have started combining the blocks with the parasternal blocks with them, and that has actually improved the quality of analgesia in these patients. So I think the breast blocks are not complex at all. They are very easy. There might be a difference between the Indian patients and the patients abroad because the surgery is done early. The detection is early, so they don't go for very extensive surgeries. But in India, some of the times the diagnosis is pretty late, so they might go for extensive surgeries. Then again, I think one of the things which was different was about because we do actually put implants, so a lot of them actually do put implants, and they are never actually subpectoral. So you don't actually have to worry about pectoral nerves in them. It is just subcutaneous, it's not subpectoral. And they have got those implants which they, fill with saline rather than actually having a silicone ones. So there are newer kind of implants which are better. Otherwise, I think Hetal has covered most of the other things, but things are changing in the way we actually manage analgesia for these patients. And a lot of things about discussed about CPS, and I think the comment about gabapentin, actually gabapentin does not actually prevent. It has been proven. It is not, gabapentins are not good for acute pain. And same thing is true for patches. Now, patches have been, if you look at the newer studies and guidelines, they say patches should not be used for management of pain. And that has actually come in the chronic pain. Anybody can look up. I mean, if you are a chronic pain consultant, look up about what are the guidelines for patches. They've said patches are not to be used for management of acute pain. And gabapentin, gabapentinoids are out of the equation again. We used to have something called lower limb protocols for knees, which included gabapentin or pregabalin, and they have been taken out now. Patches, no one uses them for that. But again, it's different practice. In India, probably it's easier. So people do use actually patches quite frequently. I mean, fentanyl patches, buprenorphine patches are used. Some patient will come with buprenorphine patches, and you can continue. There's no need to actually discontinue them. But I think putting them acutely at 24 hours before, I don't know how useful they are. I think with that, thank you very much.
Thank you so much for your inputs. And if I may just ask a question that, like in your setup, the TKRs are done under spinal or regional?
It is patient's choice. So we do actually give them a choice. So patient will actually decide whether they want to have GA or spinal. We don't decide for them. But saying that, interestingly, a lot of the patients with knee do prefer actually having spinal.
Okay.
Compared to hip. Hips is like 50-50. But
Okay.
if you look at the knee, I think a lot of patients do, prefer to have spinal. A lot of patients, we do use diamorphin if they're going to have spinal.
Mhm.
So we use heavy bupivacaine with 500 mics of diamorphin is quite commonly used. And that actually gives them a good quality of analgesia.
Okay. And patches are not used because
Never.
of continuous release of the
No, it's not because of that. I think the studies have shown that there is chances of more side effects with patches, and the absorption can be very different from different people depending on the skin. People can even abuse it. One of the ways to actually get a high with patches is you use a hair dryer on that. You increase the temperature, it will go up. And I think that is also one more thing in India. I think the absorption probably I don't know whether in summer is more than when it's in winter. So I think you have to look at it as well, especially with fentanyl. Fentanyl kick with patches is a known thing.
Okay.
You apply a hot pad on it, it will give you a kick, a high kick.
Okay. Thank you very much. Dr. Mulgaonkar there.
Okay, so I'm going to take a leave, and thank you very much.
Thanks a ton for joining, sir. Yeah. Dr. Mulgaonkar is there?
I think he's left.
Oh, I think he's left.
Left.
Okay. So you can ask the remaining questions, Dr. Das, if there are any.
There is no questions at all. What about the fentanyl now being available in India? It is Doctor. This is question to Doctor.
Dr. Hetal.
Hetal, can you please?
Yeah, basically you can use it, but I haven't used it so far. Right? It is not available at our place. So practically I cannot comment on it.
Thank you. Yeah, now, Dr. Parna, you can give it.
Yeah,
Take
actually,
start
I
with
had
the
asked in the chat, I had asked one question to Dr. Aditi that if a patient with sickle cell anemia, if the patient gets postpartum hemorrhage, then how do you treat that? Because
Just like any other patient, replace blood with blood in the first place. If
okay.
not, use colloids. And uterotonics, as I mentioned,
Yes.
oxytocin can be used freely.
Okay.
I have mentioned in the slide, carbetocin is not a SCD is not a contraindication for carbetocin. We need to use it with caution if there is preeclampsia renal dysfunction.
Like any other patient.
Yeah. Similarly, for methergin, it causes large, what I should say, extensive vasoconstriction. So again, in PIH, it's a contraindication. And misoprostol is to be avoided in asthmatics. because of the bronchospasm that it causes. So these drugs remain the same.
Okay. So methogen and carboprost, you should avoid, or
If
it's just like any other patient.
any other patient, if there is PIH, you're not going to use it.
Not PIH, I'm talking about PPH. If there's a postpartum hemorrhage.
If in sickle cell disease, if your sickle cell patients are also prone to PIH.
Yes.
Right? So
Yes.
if PIH is present, avoid. If not, use.
So if not, you can use.
Yes, ma'am.
Okay. 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 So with that, okay, Dr. Das, any more questions are there?
There are no questions till now.
No questions? Okay. So now we come to the end of the wonderful webinar that we had today. My sincere thanks to all the speakers for making this webinar an excellent and a wonderful and a very practical webinar. We really enjoyed it. So thank you, Dr. Anjali Patil. Thank you, Dr. Aditi Lele. And thank you, Dr. Hetal Vadera, for this excellent webinar. I sincerely thank our moderator, Dr. Chitranjan Das, for doing the wonderful job of moderating the session. Thank you, Scientific Committee, Dr. Nilima, Dr. Shamini, and Dr. Amrapali for their inputs and for their work. Thank you all the guests, delegates, and the executive members of SAMS for attending our webinar. Special thank you to Dr. Shiv Kumar Singh for joining and for his inputs. Thank you, Mr. Ganesh from Ganika, for providing the virtual platform. Thank you, SAMS, Maharashtra State ISA, for providing the Zoom platform. Thank you all the Thane ISINs for joining in and making it a huge success. I thank our senior executive members, Dr. Katkade, who's a GC member, and Dr. Manohar Bharne, Dr. Meenal Gadgil, who's the past president of Thane ISA, for always supporting us and for their continued support. I thank my ISA colleague and president, Dr. Manisha Ghosh, for always being there and for her valuable inputs. And we enjoyed the webinar. Thank you so much. Thank you, everyone.
Thank you. Thank you.
I just have one thing, Parna. I want to request everybody who is there to, show their videos so that we can have a group photo.
Yes, unmute. Start the video.
Stop video, everybody, please.
Yes. Thank you, Dr. Vikas Karne, for joining.
Some more.
Yes. There are a lot of senior people and a lot of executive members, and it was very heartening to see so many people.
There were 90 people. 92.
93.
91.
93. Thank you.
Okay, 93.
The highest I saw was 93, which is very good actually.
Yes.
Yeah,
It was 97 or 100 sometime in the beginning.
Oh, that's
Vaishali.
It was nice, the webinar.
Nice. Yeah.
Yes, very nice, very nice.
Very nice. Very nice. Good. Great.
Hi, Viral.
Thank you very much.
Thank you. Thank you.
Oh, yeah. Dr. Vikas has joined from Pune. Vikas is also here.
Yes, Dr.
Yeah,
Vikas.
yeah.
Dr. Sunil.
Vikas, yeah. Dr. Bande.
Hi,
Didi.
Hello,
Dr. Bande sir bhi hai. Dr. Bande sir also is here, no?
Acha, Dr. Bande is
Bande is, yeah, he is, I think, no. Maybe, yeah, he has not. Okay, great. Yeah.
Aditi, I asked you because
Well done.
2 days back only I had a patient with severe PPH. And if I were to treat a patient like yours, who comes in just suddenly. And so I wanted to be doubly sure that, yes. Yeah. Can we have a photograph now?
Yeah.
Yes, yes.
1 minute, I'll just take a capture. Dr. Hetal, your presentation was very good, very good.
Thank you, ma'am.
Completely everything was covered very nicely.
Very nice. Very nice. And practical.
Till complex pain syndrome.
Thank you.
Yes, I've taken 2 shots.
Can we leave now?
Yeah.
Varna, would you like to make some announcements?
Save to the desktop. Okay. One more picture I'll take. Wait. Yeah. Yeah. So we are all eagerly awaiting for a session of training of the technician, which is happening on 7th of Jan in Thane. And we'll be coming out with our flyers very shortly. And also we have on 14th of Jan, we have a dream run marathon, and which is organized by Solaris Hospital, and Dr. Katkade is the main person who's been motivating us for that dream run. So we'll be providing more information on those two those two programs which are coming up in January. And with that, I thank everyone and thank you for joining, and good night.
Thank you. Good night.
Thank you.
Long live ISA, long live Thane ISA.
Thank you.
Bye-bye.